Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple quick things before we get started. You can submit questions during the webinar using the questions panel, and your certificates will be available this Friday on your accounts by logging into them. Caroline, if you'd like to get started, go right ahead.
Thank you so much. And thank you everyone for joining us today. I really appreciate your time. So what I'm here to talk about, my name is Caroline Steele. I am a registered dietitian, board certified in pediatrics, and I am an IBCLC lactation consultant. And so I'm here really to talk about my favorite topic, and hopefully you will take something away with this. We're going to talk about ensuring safe handling and administering mostly human milk, but a lot of hospitals combine fortifiers with human milk or maybe supplement with formulas. And I want to talk about feedings for infants in the hospital setting and how to really promote safety. A little of my background, I've been a dietitian for 30 years and I've been a lactation consultant for 15. For the previous 12 years, I was the director of clinical nutrition and lactation at Children's Hospital of Orange County in Orange, California. And prior to that, worked in a variety of settings, but in my past, I've opened 2 centralized prep rooms where we did dedicated technicians, barcode scanning, and handling of human milk in the hospital setting. So I'm really gonna focus on that today. The other thing I worked on is I was the editor of the Infant and Pediatric Feedings book, which is a book from the Academy of Nutrition and Dietetics, which really serves as a manual for providing guidelines for hospitals. And we'll talk about that later as well. So my disclosures, I retired about a year ago from Children's Hospital of Orange County, and I am currently working as a clinical consultant for Timeless Medical Systems, which is a human milk and formula barcode scanning company. As I said, I was at CHOC prior to that, and I am a lecturer on handling of infant feedings for Medela, like today, and also for Mead Johnson Nutrition. So my objectives today are to talk about what are the risks associated with human milk and formula handling in the hospital setting, talk about the current standards and best practices, and finally, describe how centralized handling and barcode scanning can reduce errors. And so I'm not going to read this whole thing to you, but a friend of mine and the former editor of the Infant Feedings book, Sandy Robbins, at one point said, "We do all these sophisticated things in medicine, but when you look at how we handle infant feedings in the hospital setting, some of those practices are more like we would see in someone's home kitchen than a state-of-the-art medical facility." So I always think that when I think, is this really a concern? And I can tell you in the last 20 years that I've focused on this arena, we've seen a lot of changes, but there's still a lot of things we could be doing even better. So when we talk about infant feedings in the hospital setting, there's 3 concerns. There's contamination, accuracy of preparation, and misadministration, giving the wrong feeding. So I'm going to talk briefly about each of those and then we'll go into best practices. So let's start with contamination. So there's a lot of consequences of feeding contamination. A big one is just what I call feeding intolerance. And for many years, I was a NICU dietitian, and I think now back about how many times a baby had been on a certain feeding regimen for some time, and all of a sudden they were spitting up or they were having loose stools, and we changed their feeding because we said they weren't tolerating it. In hindsight, I truly wonder how much of that was due to contamination. Good old-fashioned foodborne illness. So we know that you can see GI illness if you have high levels of contaminants. Usually we talk about more than 10 to the 5th colony forming units per milliliter. At high levels, you can end up with gastroenteritis or even NEC. And we know that if those organisms go past the mucosal barrier, you can end up with sepsis. So it is certainly a concern, especially in our most fragile patients. And there's a lot of things that influence contamination. One is your preparation, location, and technique. Good old-fashioned hand hygiene, the use of sterile ingredients, the cleanliness of equipment, and that includes breast pumps. Many of you might remember back in 2017, the CDC put out a recommendation and an alert because a baby had died from contaminated breast milk because mom brought it to the hospital, but she had not been sanitizing her pump parts daily. She had been cleaning them after each use, but hadn't been doing that sanitizing once a day. And so really thinking about, even if you're doing everything you can for proper handling once it gets to the hospital, we have to help our moms be safe as well prior to getting that milk there. Refrigeration times and temperatures, both where mom's storing it at home or just after pumping to when it gets to the hospital. Hang times at bedside, the frequency of your tubing changes, and finally monitoring those expiration dates and times. That can all influence contamination. Now, when we talk about the hospital setting, I want people to remember that sterile technique and aseptic technique are not the same. We tend to use them interchangeably, but they're really not. Sterile technique is very common in healthcare, obviously. It's designed to destroy all microbes. It's very common with surgery and medical procedures. When we talk about handling infant feedings, we're really talking about aseptic technique, minimizing the presence of pathogenic organisms. So this is things like good hand hygiene, no touch technique, and having procedures to minimize introducing microbes and minimize microbial growth. So I want to take you back to a study I did many years ago, actually, not at CHOC, but at my hospital before that. I'll take you back to set the stage there. It was the year 2000, and we were getting ready to build a brand new state-of-the-art NICU. And there was not a feeding prep room as part of that plan. And I went to the administrator, the head of Women's and Children's, and I said, you cannot build a state-of-the-art NICU and not have a feeding prep room. I guarantee you it will be better. And so the administrator gave up her office in the new unit and said, you can build your prep room. And I thought, boy, I better hope it's going to be better because I just promised this administrator. So we set off to do a study. We had very high breastfeeding rates, but back in 2000, if mom didn't have enough milk, we didn't use donor milk at that time. We were supplementing with formula. What we knew was we couldn't control how mom was handling her milk, and we wouldn't know if there was microbes in the feedings if it came from mom's pumping or storing at home or us handling it in the hospital. So we did a study just looking at formula. I wanted to set the stage of why we were looking at formula here, but I think it's really powerful. So we looked at 526 samples, looked at when our nurses were prepping the feeds in the unit, so not in a centralized prep area, just in a counter in the unit, versus when we had dedicated technicians preparing it in a prep room. Now, nobody knew we were studying them, because the first thing people do when you're watching is all of a sudden they do everything different than they used to do. So we made sure no one knew we were studying them. We secretly took all these samples. And what we found, you can see on the right side of the slide here, is that powdered formulas, which are not sterile to start with, when they were prepared bedside by the nurses, 44% had microbial growth. When we switched to centralized prep with dedicated technicians, that dropped to 4%. So what that told us was that even though it wasn't sterile to start with, how and where we were preparing that made a huge difference. Then we even looked at sterile liquid formulas, and the mere act of drawing it up in a syringe at the bedside, handling it at the bedside, about 6% ended up with some microbes versus 0 when that was done in the prep room. And what we concluded was that bedside preparation was 24 times more likely to show contamination. And again, we studied formulas because we knew we had sole control over that and wanted to look at that. But I think it's really powerful to think about how we're doing things and where we're doing it. And the good news is, because the administrator gave up her office, I had good data to share with her. Okay, so that's contamination. Let's talk a little bit about preparation accuracy. So there are so many things to monitor when you talk about accuracy. You have to make sure the provider is ordering things correctly. And in our NICUs, often we are adding 1 or more fortifiers to human milk to give extra calories, extra protein to help with growth. Then we have to make sure the correct fortifier is being used, or if you're supplementing it with a formula. And then even if they're ordering it correctly, you got to make sure that you're using the right recipe, that your calculations are correct, and that you're measuring out the correct quantities. And then finally, you have to be able to track everything in the event of a recall. We know there's been lots of recalls of products going on recently, and I'm going to talk about that a little more later. So you got contamination, you've got accuracy, and then you have misadministration, giving the wrong human milk or the wrong fortifier to the wrong patient. So there is a lot of consequences of that. There's medical or infectious disease concerns. So if you give the wrong human milk to the wrong patient, you could have viruses passed. There could be exposure to meds or drugs. Giving the wrong fortifier, or if you're mixing with formula, could cause an allergic reaction, GI intolerance, metabolic complications. There could be things that happen. There's also regulatory scrutiny. So giving the wrong human milk to the wrong baby is a bodily fluid exposure. Those are reportable to the State Department of Health. They can also be viewed as a HIPAA breach. And the reason is, if I give a bottle to a mom to feed her baby, she feeds her baby and then looks at it and realizes that is not her baby, depending on what's on your label, if you have protected health information on your label, that is a HIPAA breach, and those also have to be reported. Which brings us to economic concerns. So HIPAA fines can be $25,000 or more a piece. It's possible. You're not always fined for those, but you can be. Then there's blood workup costs. If a baby gets the wrong milk, we draw blood on that baby. We have to draw blood on that baby's own mom to see if any viruses that were passed came from the own mom. And then you have to draw blood on the mother whose milk it belonged to see if there's any concerns there. And then certainly if there was a medical complication, there would be costs associated with that. All of this is true. However, the risk of getting sick from the wrong breast milk is pretty small. It is, no one wants to do it, but it is a small risk. The bigger concern is usually family satisfaction, because it can really make families lose confidence in the care you're providing. You may be providing top-notch care, but what moms think is, this bottle was clearly labeled. How did the wrong milk get to the wrong patient? And they start wondering, is my baby getting the right medications? Are the ventilator settings right? Is the surgery being done correctly? It really undermines that care. And that's really probably the biggest true consequence of misadministration. I do want to talk, while we're talking about misadministration of milk, that really means accidentally giving the wrong milk to the wrong patient. But I do want to throw in something about milk sharing here. Now remember, we are talking critical patients in the hospital setting that are more fragile, but there are risks associated with milk sharing. There's infectious disease risks, again, exposure to meds or drugs, etc. One study found that about 3% of women who were interested in donating to a milk bank weren't eligible because of viral processes, which means if they gave that milk away or sold that milk, they might not even know that they should not be sharing that. One study of internet milk samples found that 21% of them were CMV positive, which would be very concerning for our NICU population. And then finally, I mentioned earlier about the CDC guidelines for sanitizing pump parts. There is that risk of microbial growth. You don't know how that person pumped it, stored it, handled it. One study up in Canada at the Ontario Milk Bank found that 80% contained detectable bacterial growth, with 28% above 10 to the 7th CFUs per mil. If you remember GI illness, we can see above about 10 to the 5th. So there's certainly concerns there, especially in our fragile population. There was also a study done looking at internet milk sales, and what they found was high levels of bacterial growth overall, frequent contamination either with pathogenic bacteria, or that 74% contained higher than 10 to the 4th CFUs per mil or pathogens. And about 11% were adulterated. So they had cow's milk or infant formula added to it. So I do throw that out there, making sure people are really aware of that. In hospitals I've worked in, we have not allowed milk sharing. We've allowed pasteurized donor milk for anyone who wanted it, because we felt like that was much safer than allowing them to bring in milk from somewhere else. Okay, so we talked about the three concerns: contamination, accuracy, and misadministration. So let's talk through some of the guidelines around those areas. Everybody always wants to know what the Joint Commission has to say, because many hospitals are surveyed by the Joint Commission or a few of the other regulatory bodies. So provision of care 020203 says the hospital is responsible for the safe and accurate provision of food and nutrition products, and that they're prepared using proper sanitation. So think about this. This is food for our most fragile infants, which means however we're preparing human milk in the hospital should meet all those safe and accurate standards. We'll talk more about that in just a minute. Infection control regulations say that all hospital components must be part of our infection control activities. And finally, the National Patient Safety Goal says, specifically calls out human milk and says you must use 2 patient identifiers when looking at human milk. So the Joint Commission really does address safe handling in the hospital setting. So there's a lot of best practices out there. Here is the book I mentioned before. I had the privilege of working with about 21 different authors and about 40 reviewers. So there are wonderful guidelines in here. I encourage you, if you don't have this, to get this for your hospital. I get no royalty off of it. I got my 2 free copies of the book and that was it. But I think it's a great reference and you can find it at the Academy of Nutrition and Dietetics, really comprehensive. There's also the most recent publication from Himbana that came out around the same time as this. Aspen and NAN have some articles out and you'll have these handouts available so you'll see these references. So there's a lot of good resources out there to help you as you're looking at how your hospital handles human milk in the facility. But all of these guidelines have a lot of things in common. One is they all talk about a location that is physically separate from direct patient care areas that is used solely for the purpose of human milk or formula preparation and that supports aseptic technique. They talk about having specially trained staff as a best practice, making sure you have good temperature control as well as infection control procedures and quality assurance programs. How do you track and know that what you're doing is working? Talks about unit dosing, which we'll talk about in a second here, proper labeling, and then finally barcode scanning being a best practice. We'll dig into each of these just a little bit. So if your hospital applies for the US News and World Report Best Hospitals designation for neonatology, they will be asked this question. Does your hospital offer a dedicated area in the facility but away from the bedside for human milk and formula prep? And to say yes, it has to be a separate infant feeding prep room that supports aseptic technique, restricted access, no other activity in the room. And then it also asks is, do you have risk reduction programs that reduce breast milk errors, which includes barcode scanning and dedicated breast milk technicians? And I throw this out there because a lot of times nurses and dietitians will say to me, we want to implement centralized prep and scanning in our hospital, but we can't get any traction to move forward with this. And I always say, if your hospitals are applying for this, a lot of times they're looking for things they can do to enhance their application. So keep that in mind. So when you talk about best practices, let's go back to location. A separate room away from patient care areas supports aseptic technique. Think about this, it should conform to all other standards for handling food. So nowhere else in your hospital would the person who places IVs or changes diapers, none of that person would not make meals, right? So in your adult ICU, your bedside nurse does not make sandwiches, or in your PICU, your bedside nurse does not whip up an omelet. And yet we prepare food for our most fragile patients at the bedside. And so when you think about that, if we were in person, I would ask, because there's people in every group that get this right, is the most common place that you see feeds being prepared in the NICU is next to the diaper scale. It's always next to the diaper scale. And usually that's because that's the counter by the sink. And even if you have private rooms and you're preparing in that little counter by the sink, that's the sink where you're washing your hands and where you're weighing the diaper on the diaper scale. The example I always tell people is, if I was in the NICU and I washed my hands next to the diaper scale and I laid down a paper towel, because we think of paper towels, that magic barrier, and I made you a sandwich right there on the counter by the sink next to the diaper scale, you probably wouldn't want to eat it. And yet that's where we prepare feeds for our fragile babies. So I encourage us to start thinking about location. The FGI is the Facilities Guidelines Institute. If you've been involved in any construction or remodel projects in your hospital, you might be familiar with them because most hospitals use their guidelines. And in fact, some states require using their guidelines to get approval from the state for your plans. So back in 2010, the FGI said, if you are building a NICU, you need to have a feeding prep room. And then in 2014, they even updated it and said, you really need to make sure your prep room facilitates proper flow so that you're going from clean to soiled, so you're not bringing clean stuff through a soiled area. So if you do not have a prep room and you go to make remodels, a lot of states won't let you remodel without putting in a prep room. And sometimes that's the push that we need to get moving toward that practice. Another best practice I mentioned was unit dosing. So what unit dosing is instead of making a big container of breast milk, fortified breast milk, and then drawing it up at the bedside, this would be in your centralized prep area, preparing maybe 4 syringes for 12 hours worth or 8 bottles for 24 hours worth. The reason is it reduces your risk of contamination, because even if you prepare 24 hours worth or 12 hours worth in a central location and then take it to bedside, if you remember from my earlier study, even sterile formula that's drawn up at the bedside, you run that risk of introducing microbes. So unit dosing in that central location reduces that risk. It also reduces the risk of misadministration. And the reason is, if you're preparing and you label all these at the time of preparation, then you can take that individual feed to the bedside. If you have your big jug and you draw up into it and you accidentally mislabel it at that time, you could end up giving that to the wrong patient. And then if you are warming milk up where it's maybe warmer than room temperature, maybe you've thawed it and it's warmed up quite a bit, and then you stick it in the refrigerator, it might take a lot longer to cool if you have a big jug of it as opposed to individual unit dosed feedings. Warmer temperatures can result in microbial growth. So unit dosing, a best practice. And then proper labeling, that's been a big push for the last 15 years. It stemmed from the whole idea of misconnections where you could, in the past, connect enteral connections to IV. So that's why our enteral things are all purple or orange now. They don't have the same type of connections. But a lot of the best practices out there say you can't just put a patient label on your breast milk syringe or your breast milk bottle. It needs to have patient information. It needs to say what is in there. What are the contents? What's the caloric density? What is the volume and the rate or the frequency? What is the route of administration? When does this expire? Best practice is for it to say for enteral use only and keep refrigerated till used, to make sure that all that information is there. Talking about storage of human milk. Again, this is in the hospital setting. This is not your healthy term baby at home. So for the most part, freezers in the hospital, deep freezers, we usually say 6 to 12 months. If you have research grade fridges, which I have never had in my availability, you might even be able to store longer than 12 months, but 6 to 12. In the refrigerator, fresh milk, usually up to 48 hours. I have never in my practice done 72 or 96 hours. I know there's people that do. My thought has always been, and we'll talk about it on the next slide, these are fragile patients and I really want to minimize that microbial growth. Once milk is thawed, you have up to 24 hours. And if it's pasteurized donor milk, most of those milk banks say up to 48 hours. Now, there might be some criteria where you would consider a longer storage time. Like I said, I never have because I feel like I want to err on the side of caution. But what I would say is I wouldn't do it if I didn't have centralized prep in a dedicated space with dedicated staff, so that you were really controlling contamination, that you had strict sanitation procedures, that you were able to unit dose as soon as possible. The one study out there that found 96 hours to be successful, they only accessed that container once a day. So it's not like there was milk that every 3 hours they were going and drawing in out of. So if you could unit dose quickly so you weren't continually dipping into something. And then the ability to evaluate and evaluate the expression and transport conditions. And what that means is mom sanitizing this properly? Is she storing it right at home? What I can tell you is in the 90s, I did home infusion, so home tube feeding and home TPN for peds and adults. And until you've spent lots of time in people's homes, you think everybody's sanitation definitions are the same as yours, and they really are not. So I always feel like 48 hours is the right place to be. And then finally, the best practice of identifying the right human milk at the right time. What I find most common is people either do a double check or they scan right before they feed. And that's important, but that's not the only time. So this should be performed anytime you're combining bottles. If I'm mixing 2 bottles together because I'm adding a fortifier and I need a bigger volume, I should be doing a double check or scanning. Anytime I'm relabeling, if I'm drawing it up from a bottle to a syringe and I'm putting a new label on there, preventing human error, I should be scanning to generate that label or doing a double check. And then prior to feeding or at discharge. And if that is a manual check, that needs to be a 2-person verification of 2 recognized standards. So the Joint Commission defines it as like full name and full medical record number or patient ID number or date of birth. I see a lot of times in facilities, a double check is a last name and last 4 digits, or it might even be waving the bottle to the next nurse over. Hey, I'm feeding baby Jones, you're my double check. That is not a double check. And so this is where barcode scanning has really come in as a safety piece and to prevent the human error. There's a lot of healthcare safety agencies out there that have done research studies and looked at human milk barcode scanning and really feel like that's a best practice. Okay, so we've talked a little about the best practices. I want to spend some time talking about our journey at Children's Hospital of Orange County. So I mentioned before I had opened a prep room at my previous facility, and we had dedicated technicians and centralized handling. And so then when I got to CHOC 13 years ago, I was so excited about doing this because they did not have it, and I could not get anybody excited. No one was interested in making a change. We were doing bedside handling and we weren't doing barcode scanning. Really wanted to make a change in that, but couldn't gain any traction. And then we had 3 breast milk errors right in a pretty short order. And so then all of a sudden, everybody wanted to know what the problem was and how we could fix it. So we did what was known as an FMEA, or a failure mode effects and analysis. And you may have done these. Your risk management or your quality department can help you. This is a great process really for any performance improvement project you do. But what happened was we pulled the whole team together. So bedside nurses from day and night shift, dietitians, technicians, lactation consultants, people from management, clinical educators, the whole group. And we got together and we looked at every step of the process where things could possibly go wrong. From the moment mom pumped, to transporting it, to storing it in the hospital, fortifying it, feeding the baby, sending milk home. Looked at all the potential failure points, and then we scored each one of those to get a risk priority number. I'll show you that in a minute. And then we looked at what our root causes were. And doing an FMEA takes a lot of time. These were multiple couple-hour sessions, but it's actually well worth doing, because if you don't know what the problem is, it's pretty hard to fix it. You don't know where your barriers are. So this was that risk priority number. So for every potential failure point, we gave it a 1 to 10 scale of severity, a 1 to 10 scale of likely occurrence, and a 1 to 10 scale of our ability to detect it. And then you just multiply those 3 numbers together, it gives you a score. So here's what was pretty shocking. So in the blue there, we found 282 potential failure points. I mean, this is human milk. This is not chemotherapy. This is not neurosurgery. This was human milk, but 282 potential failure points. Now the scores ranged widely, anywhere from 1, which we wouldn't be too concerned about, up to 810. So what we noticed though was there was sort of a natural break in the score, or a big gap. And so we looked at the top 85 that had a score of 160 or higher. That was our top failure points. Here's what kept me awake at night though. In the green, 45% of those top failure points were detectable. That meant that 55% of them were not detectable by our current measures. And that made sense, because if I mixed 2 bottles together to create 1 feeding and accidentally mixed them up, I might never know. So we'd have no way of knowing that. Or if I fed the wrong milk to the wrong baby and then threw the bottle away, I might never know. And so we didn't have a good way to capture all those. Then we looked at the root causes. We said, okay, and I'm not going to read you all top 85, I promise you. I just wanted to give an example. So the top one that was identified by our bedside staff was they felt like the double check was not in the manner that it should be. Reading full first and last name, full medical record with both people looking at it was not happening all the time before administration. So we dug in and we said, well, why would that be happening? Availability of staff. People are busy and then they have to go find people. Ambiguity regarding the process. Like, do I check it before I add them together? Do I check it before I feed? Do I check it before I warm it? You know, what is that process? The accessibility of the armband. You know, my baby's swaddled and you never wake a sleeping baby. So what should I do in order to do that double check? And then we had people who just thought it wasn't necessary. They've had this same patient assignment for 2 months. They feel like they don't need to do that, or bad habits. So anyway, we went through all the root causes to really drill down to where the barriers were. And what we found was, at the time, our NICU alone administered over 10,000 feedings a month. At this time, our NICU was about 70 beds. The NICU there now is about 105 beds. And obviously, as a children's hospital, there can be breast milk anywhere in the hospital. But we looked, NICU alone was over 10,000 feeds. And that if a nurse had a 3-baby assignment, he or she could be handling breast milk 12 times during a shift. So there was that risk of both confirmation bias and reduced sensitivity. So confirmation bias is where your brain fills in what it expects to see. That's like those puzzles on the internet where letters have been replaced with numbers and you can still read it. It's because your brain fills in what it expects to see. If I'm discharging 100 bottles home and I'm checking each one, and 99 are for baby Ramirez and 1 is for baby Rodriguez, my brain fills in what it expected to see most of the time. There's also that reduced sensitivity because when we do things a lot, we become comfortable with it. When the first 3 errors happened, the first thing people said was, it's probably floats and travelers, right? Because we always blame the floats and travelers. But the truth is, anyone who's ever floated knows when you float, you usually are kind of terrified because you're not in your own unit. And so you're paying a lot closer attention. What it turned out to be is it wasn't floats and travelers. It was our seasoned long-term staff because our guard was down. We're more used to it and so reduced sensitivity to processes. We realized we needed to redesign our whole process. This was not only unclear, but cumbersome for the bedside nurse. Truly, you should be checking at all those points. And there's no way a bedside nurse could be doing a 2-person double check at every one of those points. We needed to either automate it through scanning or add technicians or a combination to make that an easier process. There was an inadequate double check at key points, and by having them prep their own feeds, there was that contamination risk. Then we had to think about what the consequences were of not taking action. And I think this is important for any project because we all know that not every project gets green lighted from administration. And so you have to really say, if we cannot move forward, here's the potential consequences. Our big concern obviously was patient harm. That was our first and foremost concern. But we also were concerned with regulatory citations because we had 3 we had to report to the Department of Health. 2 of them were HIPAA violations, so certainly there could be a financial impact there. And we were really concerned about family satisfaction. We knew we were providing high-level, excellent care, and we did not want these errors, simple errors that we could fix, to be something that undermined the care we were providing. So our primary considerations were we wanted to look at a proper location to prepare these feeds, how that space was set up, how we were storing things in there, sanitation procedures, accuracy, how we were going to ID at every point, how we were going to be efficient about this, and make this a very comprehensive program. So we started with location. So this is a picture of their prep room, well, half of their prep room, because standing from one side. So it's a big operation. CHOC is 333 beds. And so there's 4 prep stations in the prep room. You can see 2 of them there on the left. And there's usually 3 in use, not all 4, but there's that capacity. So we needed a place where they could have individual workstations where every workstation was set up with its own supplies. So nobody was ever reaching over someone else, potentially contaminating, potentially mixing anything up. We wanted every workstation to be freestanding. We implemented processes for thawing without using water, like we use the bead baths here. The individual warmers are great. We just thawed so much milk that they didn't have enough capacity for us. Putting in a commercial dishwasher and a drying rack. So we looked at all kinds of things that our space could accommodate. And you don't have to have a big space to make this happen. There's a lot of things you can do in basically the size of a closet. Then we looked at our storage. So you should always have restricted access for your human milk. We looked at our freezers and we wanted to make sure they were all laboratory or pharmacy grade so that they could withstand appropriate temperatures. They were all put on centralized temperature monitoring, which means 24 hours a day. If it went out of range, it wasn't just an alarm on the fridge or freezer, but it paged certain people. It let our facilities know. There was this continuous tracking. They were all on backup generator power in case power went out. And we had strict procedures in place that if this freezer went out after hours when our technicians weren't here, what the process was. We also, you can see on the left here, those bins are the white, narrow, long bins. We wanted a method that would allow no milk to ever be sitting behind another patient. So these were long and deep, so you could use the full depth of the freezer without reaching over into another patient's bin. They're also about the same height as a 2-ounce bottle so that milk could not topple into another bin. This was important to us because we realized one of our errors before we switched processes was we used to use the little pink bath basins and stick them in the fridge and heap milk in them. There'd be a big pile in there. And one of the errors was milk that got sent home with a patient. And we're pretty sure that the pile of milk toppled into another bin because, first of all, they were just sitting there, but also because we had bins behind other bins. And so it could be easy to knock bottles around. So we wanted to look at that. We wanted to make sure for our fortifiers, we had adequate storage and that no cardboard was in that space because that's also a risk. The other thing on the right here was in our new NICU, which was very individual rooms, but then the little alcoves were open to the public. And so we bought fridges and freezers with keypads on them so only staff could get into them from a safety standpoint. We looked at our sanitation and infection prevention guidelines. So things like our technicians using gowns, gloves, and hair covering, just to follow similar procedures that you would use in your hospital kitchen when you're preparing food. Hands-free sink and dishwasher and drying rack for any items that were not disposable. Monitoring, like I said, our temperatures. I encourage people to talk with your infection prevention about what sanitizers you're using. So you want to make sure you have food safe sanitizers. The purple top wipes are not food grade. A lot of hospitals require you to wipe with those first, let that dry, and then use something food grade, but I encourage you to explore that. One of the other things we did, you can see in this picture on the upper left, you can see the orange syringes in there. Those are clear drawers that you can literally just open with one finger. What we realized is when we had items in bins with lids, like little Rubbermaid bins, no one ever put the lid back on because while they were preparing, it was a pain to open the lid and get what they needed. And so consequently, that was a contamination risk because there was never any lids. So we got drawers that you could easily open and close. So some things for consideration. We looked at our orders and calculations. So we tried to make things easy for our physicians. You know, our breast milk order had many drop downs in it. So if they chose an item that maybe wasn't appropriate for the patient's age, they would get an alert. We trained our techs to watch for maybe things that were entered incorrectly. And then we made sure that we had both automated processes, our barcode scanning system did our calculations for us, but that our techs knew how to do manual processes in the event of a downtime. We looked at our measurements. If you're doing any powdered additives to breast milk or if you're making powdered formulas, That should always be gram scale in the hospital setting because it's the most accurate. They have found that the scoops in the can, not that they vary, but how even healthcare providers filling them can vary by 40% because of how much you pack it, or if there's that little pocket of air, things like that. So making sure you're using gram scales. For liquids, using syringes, 2-ounce bottles or graduated cylinders. The big 8-ounce bottles are not very accurate measurements. And again, this is the hospital setting where we're doing a lot of fortification. At home, that's a little different, but making sure that you're very careful with your measurements. And then finally, we looked a lot at barcode scanning. We wanted to reduce the risk of human error. We wanted to improve our efficiency. And we knew that not all scanning systems were created equal. We knew that we could scan in our EMR, but all that would tell us is if this milk belongs to this baby. But we wanted it to do more than that. So we wanted to eliminate, obviously, the extra staffing needed for double checks at all the key processes. But we wanted to automate all our recipes. So we wanted something where the order would go from the EMR into the barcode scanning system, and it would calculate based on the order, based on the volume and the frequency and the calories, exactly how much milk and how much fortifier to add, whether it was a liquid fortifier or a powder or a protein modular. We wanted a system that could do that. We wanted a system where we could scan not only mom's milk, but every formula and every additive, where it would confirm that that matched the order and that it would track the lot number and expiration. We wanted to automate our labeling so that based on when that milk was pumped, that it would know exactly when it was expired, that it would know exactly what was in it, who had prepared it. All those things I said were best practices in labeling. We wanted the system to do for us without us having to manually do that. Same with automating those calculations. And then finally, automate our inventory and our recall tracking. So after we implemented our scanning system, we found that we saved about $16,000 a year because we could have better tracking of all of our products. Again, we were a children's hospital, so we had lots of metabolic products and things as well. But just looking at fortifiers for mom's milk and things we were using in the NICU, because we were able to have a better real-time inventory of exactly what we were using. Recall tracking is also important. As we are all aware with the news, there's been a lot of recalls recently. But even before all this, back in 2019, there was a recall of a formula product that could be added to breast milk or fed individually, that we entered it into our scanning system. We ran a report. We knew exactly who had gotten it. We knew if anyone had taken samples of it home. We had that whole report. There were no adverse effects, and we were able to follow up. But about 3 weeks after the recall, someone from the FDA field office in Southern California walked into my office unannounced and said, "You need to show me how you managed that recall." And prior to us having our scanning system, all I would have known is whether the product came into the hospital. I would not have known who got it, and I would not have been able to track that level of detail. So I encourage you, if you're looking at scanning of your human milk, keep in mind all your fortifiers as well. Okay, so in the last few minutes, I want to talk about our outcomes. To give you an idea, we handled a lot of mom's own milk at CHOC. So this goes back to 2014 up through 2020. So in 2020, mom's own milk, no donor milk counted here, we handled 143,000 ounces. And I share that because the more milk you handle, the more likely you are to make an error. And so that's why I want to show these are big, big volumes. Prior to any centralized handling or barcode scanning, so in this first column here, we had those 3 errors in about 2.5 years. That's what started that. After we implemented centralized handling and barcode scanning, we tracked that data for 7 years. We just published our 7-year study back in October in Nutrition and Clinical Practice. And we found that in 7 years, there were 1,226 errors, which means that we had more than 3 errors in that time frame. 1,226 wrong scans where the system prevented that. Now, some of those probably would have been prevented by a 2-person double check, but my guess is it prevented a lot of actual errors. What was also interesting was 77% of those occurred at the bedside. Now, people thought that the technicians who were preparing for 50 or 60 babies at once might be more likely to grab the wrong milk, but it was actually the opposite. The bedside was more likely to grab the wrong milk because the technicians had one sole focus. Our nurses are pulled in so many different directions. We need some systems to help support them. So to give you an idea, that's about 175 wrong scans a year, or about once every other day. It's pretty common. Expired milk. Prior to centralized prep and barcode scanning, no one ever reported trying to feed expired human milk or donor milk. But in the 7 years that we tracked it, there were 2,100 expired feeds scanned. That's 300 a year, about almost one a day. So we know that it was happening. We just didn't have a mechanism for tracking it. And then finally, we combined fortifiers and formulas together, but wrong fortifier or wrong formula, again, 0 reported prior to this. We added formula and fortifier scanning later. So in the 2.5 years we were doing that, there were 480 wrong scans at the time of prep. So that alone, we know improved patient safety. So some final thoughts here. I love this picture. This is from Essentials of Pediatrics for Nurses, which is a textbook from 1936. They have an entire chapter on the hospital milk room. And I love it. Here's the people working in the milk room, and up in the right corner there, you can see the dietitian's office. But they talk about, this is the location where infant feedings can be prepared in a satisfactory manner. Remember, this is 1936, so they're using different language, but they talk about a separate room with no other function, using clean technique at all times, and they talk about preventing contamination. They talk about using scales for weighing things and precise recipes. They have advice on equipment and staffing needs, and they talk about how staff in the prep room should not be doing any patient care. So it's interesting that in 1936, this was put out there as the standard, and it's taken us 90 years and we're not all quite back there yet. So I think it's important to kind of regroup and really think about this topic. So just in summary, regulatory standards reference the proper handling of food and nutrition products for all patients. So this means human milk that we're feeding at the bedside throughout our hospitals. We need to think about what that proper handling is, and are we handling it the way we would handle food in other areas. Centralized preparation and barcode scanning are considered best practices by a lot of professional organizations, and there's a lot of research out there. The good thing is, when I was first opening my prep room almost 20 years ago, there wasn't a lot of research on it. So it was hard to make that case. And even at CHOC about 13 years ago, there still wasn't a lot of published studies, but now there's a lot of great published research out there where hospitals have added technicians, they've added a centralized prep room, they've added scanning, and they've shown how much improvement they've made. So there's a lot of good research, and a lot of the articles are cited here to help you if you're trying to make a case for that. And we know that both family satisfaction and staff satisfaction have been tied to this. Our families know that their milk is so important that we have a dedicated room. We always tell them it's like a pharmacy for your milk, where our technicians are watching every drop of it and they're paying close attention. And we know that our nurses found it beneficial because they could focus on taking care of the patient at bedside and have that feeding ready to go without them having to come away from the bedside and prepare that and be taken away from that patient care. So I want to stop there, and I know Kim is going to go through questions on the chat. So I do want to open up the last 10 minutes or so for questions.
Great. Thank you, Caroline, for that great information. It looks like we do have about 12 minutes for questions and answers. So if you want to submit your questions through the questions panel, we'll try to get to all of them before the top of the hour. The first one that came in is, can staff wear aprons instead of a gown?
That's a good question. I don't see a problem with wearing aprons. The idea is, especially if you're doing fortification or something where maybe powders are getting on you and then you don't want that to cross-contaminate. So making sure aprons or changing frequently. But yes, I think any sort of clothing covering would be appropriate. Mm-hmm.
Okay, thank you. The next question is, it is not easy to have a separate milk prep person in a smaller NICU. Any suggestions?
Yeah, that's a great question. And you're right. And I completely feel your challenge there. Some hospitals that I've seen do things, take someone that's maybe like a unit support person or unit assistant to help with some of the processes. And that I've seen be successful because it does not have, like at CHOC, we had licensed technicians. We used registered dietetic technicians, but you don't have to do that if you have your system set up so there's proper oversight. So I have seen that where even maybe unit secretary or some other support staff do that. I've also seen units where they will sort of relieve each other, have a nurse go into a dedicated space so they can concentrate. Maybe they prepare all the feeds for their shift or into the next shift so that they can focus on that, and then they swap with another nurse. So I think looking at some creative things like that, tapping into pharmacy technicians or food service workers or diet technicians, maybe in other departments that have other duties during the day, but maybe could come up for 1 or 2 prep times during the day.
Okay, thank you for that. The next question is, do you have a recommendation on comprehensive expiration times, fresh versus thawed, fortified with human milk fortifiers versus Prolacta, donor human milk, and any sources that you use to determine expiration times?
Yes, good question. So the in general, and then I'll say that like different manufacturers, I would go with their recommendations. So like Prolacta has on their site what their recommendations are. So I would definitely go by those, same with the fortifiers. But in general, and what I've always used in practice is the clock starts ticking. So if it's fresh, it's 48 hours. But the minute you fortify it, it becomes 24 hours. Now, if it was fresh and your clock is already down to 20 hours and you fortify it, it's still 20 hours. Like you don't get to bump that back up to 24. If it's thawed, it's 24 hours. And again, when you fortify it, if you're down to 20, you don't get to back that clock up, so to speak. Most donor milk, they say 48, but when you fortify it, unless you're fortifying with Prolacta, usually Prolacta, they say if it's donor milk and Prolacta, it's probably 48. Otherwise, other fortifiers, it's usually 24. This is why, and it's a complication. My bedside nurse has said, this is why it's so confusing, because we have to think about all these different factors. That's why we went with a scanning system that did all that for us. So it knew if it was fresh or if we had thawed it, it knew the type of fortifier and it automatically calculated it, because it is a lot to consider if you're managing a lot of milk.
Okay, thank you for that. Looks like we have about 8 more minutes, so we'll try to squeeze in as many questions as we can. The next one is, when designing a new NICU with individual patient rooms, do you recommend individual refrigerators in each room?
That's a good question. Personally, I wouldn't do individual fridges, and here's why, but there's pros and cons to each. What I will tell you is in our hospital, we had individual fridges in our oncology unit. So we're all children's hospitals in oncology. And it was designed for like parents to use a convenience fridge. We had so many regulatory issues with it. They wanted to know how it was being cleaned, who was cleaning it, what if a patient changed rooms, what about temperature monitoring, that even just having it there was kind of a nightmare, and we pulled them all out. So in the NICU, I think that could also be a challenge. The other concern I had with centralized prep is our technicians were regularly picking up and delivering, and I didn't want them going in and out of patient rooms all the time, because that's not always possible or appropriate for them to be doing. So from a logistical standpoint, it was also, staffing. So I had technicians delivering all over the hospital. And so to deliver in 50 different rooms as opposed to maybe 3 refrigerators in a unit, or 105 bed unit, 5 refrigerators versus 105 spaces. So that, from a logistical standpoint and how we saw that in our oncology unit, I would lean towards centralized refrigerators, but I can also see some benefits of that. I think the other challenge is we didn't want moms just grabbing and feeding, like when you get more to that feeder grower phase where mom's doing things, because we wanted to make sure everything was scanned before feeding. So I can't say you shouldn't do it. I'd say that was always my hesitation to doing it.
Thank you. The next question is, what system are you using for scanning prior to mixing?
So and this was part of my disclosure too. So at Chalk, we used Timeless Medical. We had used it. Now they've had it for 9 years, and I'm doing consulting for them to help with improving that. So not trying to sell you Timeless, but we liked Timeless because it did so many of those features we were looking for.
Okay, thank you for sharing that. The next question is, what is your recommendation on sharing the same room for both medication room and breast milk prep room?
Yeah, that is a challenge because I think it also becomes a challenge from pharmacy regulations. Where I've seen it successful is where I've seen units where they have literally sort of separated the room, put in like a little plexiglass on the counter, like a splash guard basically, and had a med prep area and a feeding prep area. But I would definitely, if you were wanting to do that, also work with your pharmacy, because you'd want to think about, like, if your nurses were prepping there, that's probably not a problem. But if you have technicians, then are they allowed to have access to the pharmacy room? So thinking about some of those things, I would just make sure they're quite separate. Most of the guidelines do say, like if you're doing new construction, do say that it has to be physically separate where it is that sole purpose. So I think there's things you can get in, especially as an interim, like if you're trying to make an immediate change without any remodel, but I would just try to make those very separate.
Thank you. The next question is, can you please talk about labeling and scanning for multiples, such as twins, triplets, etc.?
Yeah, so in a case that most places want, if you have mom's milk, you want to be able to use it for any of her multiples, and we did the same thing. What we did then is once the feeding was prepared, we assigned it to a specific patient. And the reason was we knew, for example, with twins, one might be on 22 cal per ounce and one might be on 24. And so we didn't want to give the wrong milk to the wrong patient, or the wrong feeding, or they might even be on different volumes, even if they were on the same calorie level. So we don't want to waste milk by accidentally feeding the wrong volume to the wrong patient. So how our process worked is when we scanned it, it knew it could belong to any of those patients. And then once you prepped it, you added the fortifier and you portioned it out in its unit dose, then it was assigned to that specific patient. I do know hospitals that at the time they receive mom's milk, divide it because they want each twin or each multiple to get an equal amount. So certainly that's a possibility. We didn't do it that way, but we really felt like once it was prepared, it belonged specifically to that patient.
Okay, thank you. We're going to try to squeeze in a couple more questions before the top of the hour. So here's the next one. Is there a training program that you recommend to train these feeding techs? We are using nursing assistants for our infant feeding room and have created our own training. Just curious to see what else is available for our team.
Yeah, there's a couple training programs out there. One starting with the blue book, the Infant and Pediatric Feedings book, there is a CEU module you can buy to go with it that has like some question and answer. So some people have used that as their training module. There's an online program from Ohio State University. It's through their extension program. If you just type in Ohio State University infant feeding, it's got a course, and like you can get credits for it. So like if it's a pharmacy tech or a diet tech or something, they can get credits for it. But nursing assistants could definitely do that. There's different modules and there's homework assignments, but they can do it at their own pace. The modules are recorded. I did some of their lectures and there's quite a few other lecturers on that. So that's an option. Columbus State Community College has a program. You can Google that and pull that one up. They customize it, and at least pre-COVID, they used to come out to your facility and they could help you like look at your processes, come up with ideas. They can even help you with design, construction. And then a company called DM&A, Don Miller and Associates, they also have an infant feeding technician sort of program that they're building out, and they have a lot of expertise. So there's a few out there that really have some good training modules.
Thank you, Caroline, for all that great information you've given us. We're just about at the top of the hour, and I want to be respectful for everyone's time, including yours. So just a couple quick things before we end. Your certificates will be available this Friday by logging into your account. And at the end of the webinar, once we close it, an evaluation window will open so you can fill out your evaluation for today's webinar. And registration is now open for our June 15th webinar. You can visit medilaeducation.com for more information and to register for that. And I hope everyone has a great afternoon. Thank you again, Caroline.
Thanks for having me. Bye-bye.
You're welcome. Bye-bye.